Hello, everyone, and welcome to another deep dive session with Pekga, Practical EKG Academy. Today, we're going to be taking a look at this 12-lead ECG. Of course, we're going to be building it up from the single channel as usual and working up to that 12-lead. Before we get into it, I do want to remind you, as you're developing your ECG interpretation skills, focus on developing your own method. This is something we use at Pekga here. You can use any method, take somebody else's, it doesn't matter, but it's greatly going to help you when you run into difficult ECGs, when you're tired, when you just don't know what you're looking at, or maybe you just don't want to be looking at any more squiggly lines. What we use here is pretty straightforward. Take a look at what stands out. Then we go into measurements, try to correlate that with any symptoms or any events at all that you can make a correlation with what you're seeing on the ECG, and that will give you a chance at decent ECG analysis, possibly even a full diagnosis. Okay, so let's get to it. So let's say somebody hands you this 10-second strip, right? Pretty common lead to the most commonly used lead. And of course, anytime somebody hands you a single channel strip, the best you can hope for is to get some rates and maybe even discern a rhythm. Now, this ECG is a little bit tricky. I shouldn't say that. Most of them lately that I've been running into have been pretty tricky. But this one is on the trickier side. So let's get to it. I'm looking at this ECG, and the first thing that stands out to me here is the width of the QRS, right? So this QRS is kind of wide. So my mind immediately goes to bundle branch blocks. So there's some sort of a conduction delay going on here, and that's kind of supported by this inverted T wave. That could be a secondary repolarization characteristic found with bundle branch blocks. So let's get to it. First thing I'm going to do is I'm going to try and get the ventricular rate, or the heartbeat rate, right? Ventricles are what squeezes the blood into the system, so that's the rate that's most significant to us most of the time. So just quick and dirty, okay? Quick and dirty here, just R to R, peak of R to kind of roughly peak of R. This is 300, 150, a little bit less. I would say that our ventricular response is at 140 beats per minute. Okay. Now I'm going to zoom out a little bit and look at this. We have something going on here. This signal, this portion of the signal, it appears to interrupt what's going on here. So the QRS complexes that are coming in here, they seem to be pretty regular, with the exception of this and this as well. So this appears to be a little bit early, but it's so wide, it's so ugly that I'm just not sure if this is regular, if this is a single interruption. So to kind of double down when it comes to my rate, what I'm going to do is I'm going to average it out. So I'm going to count all of the QRSs, including, I'm suspecting that this is a real QRS. So again, this is an assumption, but I'm going to include it in my average. So I'm just going to count these out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Okay, I am seeing 23 on here. So there's 23 QRSs here. This strip is 10 seconds long. To get a full minute, so I can get my beats per minute, I'm going to have to multiply this number by 6. So I'm just multiplying this by 6. And 6 times 23, 120, 18, 138. Okay, 138 beats per minute. If that is indeed what is going on. That's pretty close to the eyeball average here. All right, so one rate down, we have a ventricular rate of 140 beats per minute, supposedly, allegedly, right? Now, the next thing that's really catching my eye, what I'm looking for here is atrial activity, and I'm just not seeing it, but what I am seeing is this weird stuff, right? I don't know if you can kind of pick that out, but I'm just kind of going through the ECG here and seeing where I can find these little blimps. There could be more. I'm just kind of throwing darts, arrows onto what stands out to me. So right now I don't know what I'm dealing with, so I'm just trying to get as much information as I can here before I start making any sort of assumptions, conclusions. Okay, and what I'm going to do here, and this is the reason why I'm doing this, so if you're looking at this strip, this little anomaly to this little anomaly, there's so much of a distance. If we take a look at it over here, this distance, just eyeballing it, appears to be the same as this distance, same as this over here. So just roughly, this is an eyeball estimate, right? But here, it gets a little busier. So this could be that I'm just getting a truer picture of what's going on supposedly in the atrium. Again, this is an assumption, so I'm just gathering data to help me discern and evaluate what's going on here. So I'm going to take a look at this. I'm going to zoom in here, and I'm going to make an assumption that this indeed is a P wave or just atrial activity. And then over here we have another one, and over here we have another one. Now I'm going to measure the distance between these two. This looks identical. So here we have 5, 10, 15, 16, 17, roughly 17 small boxes. Okay, same thing over here looks like at 5, 10, 15, 17. Okay. So there's, this activity, it seems to be consistent. And I bet if I were to kind of, you can take a little sheet of paper, like a Post-it note, make a couple of marks on it, and then kind of paste this out, right? I bet if we started doing this, this would line up. So 5, 10, 15, 12. We should be looking at a signal happening right here. And just looking at this right now, see the top of this QRS? It lines up with this one. But here where we're supposed to be getting some atrial activity, the QRS is a little bit higher. See that? And that could be atrial activity superimposed on the QRS. This level of discernment, this level of just eyeballing things and trying to figure out what what's in front of you is absolutely necessary when you're dealing with ECGs. So it looks like we do have atrial activity, and I'm going to use the 1500 rule. So I'm going to take 1500 to measure the rate of this atrial activity divided by 17. Now, I'm not this good at math, so I'm going to use my calculator here. All right, and what we get is 88 beats per minute. So if this indeed is atrial activity, it's happening at a much lower rate. And the ventricular rate is faster. Whoops. The ventricular rate is at 140. The atrial rate, supposedly, if indeed it is atrial rate, is happening much slower. So my mind immediately goes here to AV dissociation, atrial ventricular dissociation. Now, what the hell is that? If you're hearing this term for the very first time, what we have here, we measured out some sort of ventricular point, right? It appears to be driving the rhythm at 140 beats per minute. So there's 140 signals here being emitted per minute. In the atrium, it appears to be working the sinoatrial node. Whether it's exactly the sinoatrial node or an ectopic location, I don't know that yet. That is happening at a slower rate. Okay? And this is what's known as AV dissociation, atrial ventricular dissociation. So one is not related to the other. One is not affected by the other. And that is a hallmark feature of ventricular tachycardia. So in case you suspect ventricular tachycardia, or in case you get atrioventricular dissociation, if you see that on an ECG, there is a really, really high chance that you are dealing indeed with ventricular tachycardia. Now, this doesn't quite, fit the morphology of a typical ventricular tachycardia. So you open up any textbook out there, and anytime you're shown ventricular tachycardia, it's far more aggressive looking. This just looks like a Bunner-Branch block. But the information we're gathering, it says that we have a ventricular rate that's faster than the atrial rate, meaning it's driving the heartbeat. Okay, it's driving the rhythm. Okay, that's the main. How can I say this? That's the main force behind what's forcing the blood into the system here. Okay. All right, let's keep going. Let's see what else I can get. I'm going to have to come back to this and try to figure this out. But so far, it looks like we have, I'm suspecting strongly, ventricular tachycardia. Okay, let's see if we can prove that. Now we're moving over to three channels, and here, oops. Here we have our channel 2 that we were just looking at, and then we have an addition of channel 5, V5 and channel V1, or lead V1 and V5. V1 pertains to the right side of the heart, V5 pertains to the left side of the heart, roughly speaking, okay? So, looking at this, the first thing that jumps out at me is our squiggly line. Squiggly little beat here. When we take a look at it and compare it to other leads, we get some sort of a QRS complex. Now this in particular here is known as a fusion beat. It would be ideal if you could have normal sinus rhythm for this patient and then kind of compare it and see what this is. But just eyeballing it, it's still kind of wide. So when you take a look at this beat, this is still 1, 2, roughly 3 boxes wide. It could be a little bit wider, it could be less wide. I'm just uncertain. You just can't get a decent, the resolution is just not great. And I purposely use these ECGs just because when you deal with ideal stuff, great, and then you get out into the real world and you get something like this, and the first thing you want to do is just give up or hand it back to whoever handed it to you, and, go take a break. But that's not the case. A lot of times you'll have to deal with stuff like this. So here it appears that we have a fusion beat. Fusion beat in correlation with atrioventricular dissociation, which is what we appear to be looking at on that first screen. These are both hallmark features of ventricular tachycardia. Now again, looking at this just looks like a Bunner-Branch block, but where's your atrial activity? Speaking of atrial activity, we were looking at these little blimps here, and if you take a look at these blimps and you compare it to other channels, that little blimp is present in other channels as well. So this indeed is real. Okay, that's one. Here's another one. See that? So this is real. And here's another one that I didn't see initially. See this one right here? Oh, actually, I did see that one. Well, maybe not. Maybe not. Doesn't matter. The point is, whatever this anomaly is, it's showing up in all of the leads. So it's not a fluke, single channel, somebody tapped on the wire or something like that. It's real. And I would say that, yes, indeed, we do have atrioventricular dissociation. We do have a fusion beat. Now, what's a fusion beat? Fusion beat is pretty much like atrioventricular dissociation, or it's directly associated to it. So what's happening is you have the ventricles driving the rhythm in this case. The heart rate is at 140 beats per minute, right? So this signal here is depolarizing the ventricles a lot quicker than the atrium. However, every so often, the atrial signal gets through and it starts depolarizing the ventricles. So the atrial signal gets through, starts depolarizing the ventricles, and then what happens is the signal from the ventricles also shows up. So the ventricles are being depolarized from two sides. One is from the atrium, and the other is from the irritated focus in the ventricle. And what happens, that signal that starts coming down normally, all of a sudden there's an addition of this weird, ventricular episode that's happening, and you get this fusion beat. You get a combination of a regular beat and a ventricular beat, a regular beat and a PVC, if you will, if that helps you imagine it, although we're not dealing with PVCs here. Okie dokie, so that's a fusion beat. So far, I have enough information on here to, definitively say that we are looking at ventricular tachycardia. Now, definitively, I hate to use that word because there's always something that pops up or makes you think twice. But fusion beat, atrioventricular dissociation, ventricular rate is faster than the atrial rate. This, to me, looks like ventricular tachycardia 100%. But let's keep going. Let's keep going here. So far, just to kind of recap, we do have atrioventricular dissociation. We do have a fusion beat. Now look at this lead 1. It looks benign, if you will. But if you take a closer look at it, you can see that the bottom portion is bigger than the top portion. In other words, we can say that lead 1 is negative. When we go to our axis, this is your lead 1, right? This is the positive end over here. This is the negative end over here. So if lead 1 is negative, immediately this puts us on this side, on the right side of the axis of deviation. So what we have here, what we're looking at, in addition to atrioventricular dissociation and fusion beat, is right axis deviation, which also adds to the prognosis of ventricular tachycardia. Okay. Now, if I'm suspecting ventricular tachycardia, and before I get into suspecting ventricular tachycardia, look at our fusion beat. Look at this. So it comes on time. It comes on when you would expect it, maybe a little bit early. It doesn't matter, but it just looks like, hodgepodge of something going on. And that's exactly that atrial signal in combination with the ventricular signal, or ventricular depolarization. Now, if you do suspect ventricular tachycardia, and so far this would be enough to call it ventricular tachycardia, but let's see if we can get anything else out of this ECG. So I'm looking at this, and this has left monobranch morphology. With left monobranch morphology, I can use Brugada criteria. And when it comes to ventricular tachycardia, because this is an extremely, extremely difficult topic. So typically when you go out in the classroom somewhere, or you open up a book, there's going to be a picture of a very aggressive, wide rhythm, and they're going to say monomorphic ventricular tachycardia, QRS is wider than 120 milliseconds, the rate is greater than 100 beats per minute, and they're going to chalk it off and say that's ventricular tachycardia. And you get out in the real world and you see that there are many things that can mimic wide complex tachycardias. Or that is, in the group of wide complex tachycardias, some of them are ventricular tachycardias, but some are not. Okay, some are just mimics. So you might have a presence of a bundle branch block, which we would call an aberrancy, and not to get not to confuse the subject here at hand, but going back to left monobranch morphology. So left monobranch morphology, I'm using the Brugada criteria, and I don't have the exact criteria here up on the screen, but you can look that up. But one of the things when it comes to one of the criteria in one of the characteristics in the Brugada criteria is if you have a notching, see this notching here? See this little notch? As this deflection is happening, See this little notch here? So it's not a straight line, there's a little protrusion. That little notch is called the Josephson sign. And it is highly indicative, or finding that sign in leads V1 or V2 highly favors the diagnosis of ventricular tachycardia. Another thing we can pull off of the Brugada criteria is the, well, let's see what I can use here. We'll use this. Okay, so when you measure the onset of the QRS from the onset to the nadir, or the peak of the S wave, if that distance is greater than 2.5 small boxes, so if it's greater than 100 milliseconds, again, this is another sign which favors the diagnosis of ventricular tachycardia. That is known, this right here is known as the Brugada sign. So this is one of the criteria that I just kind of pulled out of the hat quickly. There are many used to discern ventricular tachycardia. And if you want to get good at diagnosing and discerning ventricular tachycardia, you have to know them, or at least be able to look them up rather quickly. But you realistically, you do have to know them, or at least kind of know of them, and then be able to go back to one of those criteria and pull it up. Now, looking at this, if you were to give this to a relatively new student, they might say, okay, this looks like left bundle branch block. There's some sort of ischemia going on. It's probably related to the left bundle branch block. It's fast, and they might say this is sinus tachycardia with a left bundle branch block. And they would be absolutely wrong. So here we indeed do have ventricular tachycardia. The information up here supports the conclusion of ventricular tachycardia. And what is ventricular tachycardia? That's something to address before we part ways today here. So ventricular tachycardia, I'm just going to get rid of this. So you know, ventricular pertains to the ventricles, right? Tachycardia is just a fast heart rate above 100 beats per minute, or 100 beats per minute or greater. So this phrase is telling us that we have a tachycardia which is originating in the ventricle. So some group of cells here is irritated enough to start firing off on its own. And in this case, it's firing right at a rate of 140 milliseconds, beats per minute. But it's not affecting, so this signal is not penetrating the atrium, and the atrium is able to conduct signal at a slower rate. But the ventricle, this little point right here, is what's driving the rhythm. That is ventricular tachycardia. Depending on where this signal is coming from, so if this signal comes from here, you're going to have a different morphology. If this signal comes from here, you're going to have a different morphology. If that tachycardia comes from here, you're going to have a different morphology on the ECG. If it comes from right here, you're going to have a different morphology. You get the point. Now, looking at this over here, left bundle branch morphology, generally speaking, should place that tachycardia in the right ventricle. Okay, so if you have left bundle branch morphology, your tachycardia is most likely coming from the right ventricle. Going back to the ECG here, I'm looking at the inferior leads now, leads 2, 3, and AVF, and they are upright. So the QRS on them is positive, meaning the signal is moving towards those electrodes. Okay, so here's lead 3, okay? Here's lead 2, lead AVF, and here's lead 2. Now these are the positive sides, the positive ends, the positive tips, the positive electrodes of these leads. And if the QRS is upright in those leads, it means that the signal is moving towards them. Okay? Which would place the point of origin somewhere higher. So what that tells me, looking at lead 3, lead AVF, and lead 2, is telling me lead V1, right, had left bundle branch morphology, meaning the signal is moving away from V1, right? So what this is telling me, that this signal, this ventricular tachycardia, it's originating somewhere in the basal region of the right ventricle. So somewhere up here. Now, why am I talking about that? Ventricular tachycardia is an extremely complex topic. The more information you can pull off of a single ECG, the more confidently you'll be able to say to yourself and to everybody else around you that yes, indeed, this is ventricular tachycardia, and this is the reason why. Again, extremely, extremely complex topic. I have been fooled before with slower rates and QRSs that are near to normal, when in fact I was looking at ventricular tachycardia. But we get better every single day, and we learn from our mistakes. So take the time to measure everything out, right? Go back to your method. Really, really focus on what your method is forcing you to do. Measure everything out and make the right conclusions based on your analysis. All right. I think I'm going to wrap it up right there. As far as the deep dive goes, this can get a whole lot deeper when it comes to ventricular tachycardia. One thing to mention, ventricular tachycardia, this one looks pretty nice, right? The problem with ventricular tachycardia is it can often spiral into ventricular fibrillation, and ventricular fibrillation is a step away from, cardiac arrest. So that can be a pretty deadly scenario. Now, some ventricular tachycardias are more aggressive, more alarming, more deadly than others. Some are benign, if you will, if I can use that word. But anytime you get ventricular tachycardia, red flag has to go up. And please be careful, measure everything out, and make the right conclusions. Thank you, guys, and we'll see you in the next one.